Okay, fine. Great. Good evening, everyone. Well, thank you all very much indeed for coming. This is a slightly overwhelming number of people to have to talk to. I was expecting just to be speaking to Rory and my mother, to be honest. And to be sure, you can't take this back. Is that right, Rory? That the qualification is installed? Great. Okay, so I'm going to tell you a bit of a story of how I came to be here, a story of how I became a kidney doctor and how I became a professor of renal medicine and clinical trials, and I hope it makes some sense. There are a lot of thanks to be made. I'll make some of them during the talk and some of them at the end, but I'll say now, if I forget anybody, I haven't. I'm really very grateful to you all for coming and for all of your support. So I was born in Abingdon after my father's job took us as a family there before I was born, and this is where I went to primary school, Dunmore Primary School in Abingdon. And I think that's me a few years in. This was actually the peak, I think, of my sporting career. Occurred at this school. So that bit of grass there was both my Wembley and my Lords. I managed to captain the football and the cricket team while I was at Dunmore, and that was probably the pinnacle of my achievement. It was probably also the first time I ever experienced imposter syndrome, where you end up, when you're doing something, you think you're manifestly unqualified to do it. And that was because the year above me at Dunmore had a fantastic football team, absolutely brilliant. And they entered a school competition and got all the way through to the very national finals. They got down to the final itself, the best two schools in the whole country, primary schools, playing at Wembley no less. And I can remember going along to support them. But to do that, the school was given a football strip, which said Dunmore School on it, and it said Smith's Crisps football competition. So that then became the school strip. But that was the year before me. The next year I was captain, as you say, so we all got to put this strip on. And while we were, and then go into the first rounds of this competition. So the first rounds obviously started with some other local Abingdon schools, and we walked out onto the pitch wearing our Smith's Crisps finalists strip, looking quite, I think, intimidating, and we lost every single game and got knocked out. But it did give me a good experience of what imposter syndrome might feel like. From there I went to Abingdon School, where my father was teaching, and so I was very familiar with the school, felt completely at home there. That's it, looking pretty much like Hogwarts. And I made some amazing friends there, some of whom are here tonight, for which I'm very grateful. And we had a lot of fun together, we learnt a bit as well. But the one thing I can remember learning from Abingdon is that there's always somebody cleverer than you in the room. And actually not to be too put off by that, and actually to accept it, to enjoy it, but also to remember that you don't have to be the cleverest person in the room to be effective. So from Abingdon I then went to Cambridge, and this is a picture on the left there. That's Corpus Christi College, Cambridge, the oldest continuously inhabited court in Oxford or Cambridge, and the loos definitely make you feel like that. And I had a fantastic time there, 3 years, made a lot of friends, and particularly 6 or 5 other friends, because it's a very small college. I chose it basically because my English teacher told me they're not going to ask you for S-levels, which were a qualification I didn't really want to have to take on, and that he thought it was a good place to go. And I trusted my English teacher, so there I went. But I made some very good friends, and those medical students, we were a very close-knit group. And I think the lesson I learned in Cambridge that it's good fun to have individual success, but actually it's a lot more fun to succeed as a group. And that's what we tried to do. So from Cambridge I then did the unmentionable thing of abandoning Cambridge and coming over to Oxford to do my clinical studies. I was actually based at Magdalen College here, but I'm not showing you a picture of Magdalen because I hardly spent any time there at all. The picture I'm showing you instead is the house, which is the medical students' common room, if you like, on the John Radcliffe campus. And I spent a lot of time there, and when I wasn't there, tried to drag as many friends as possible, as frequently as possible, off to the mountains and drag them up some hills. And again, a lot of fun was had. After that, I did house jobs, so the beginning of medical training in Oxford and then in Bath, and then I went to Northampton General Hospital to do some other training. So I think the first question I want to ask, I'll try and answer, is why did I choose renal medicine? And I think when you ask doctors why did they choose the speciality that you see them practicing, you sometimes learn quite a lot about them. It can be quite revealing about their character. I'm not sure it is for me. When I was finished my A-levels, my mother, who knows a lot of people, knew that I was going to be at a loose end that summer, and knew somebody who got me an interview to be a healthcare assistant on the renal ward at the Churchill Hospital. And so I had an interview with the sister. I can't remember what she asked me, but they decided to employ me, which was great. And so I had a happy summer on the renal ward, learning all sorts of things that they just don't teach you at school. How to make a hospital corner when you're making a bed. What Clostridium diarrhea actually really smells like. And other things. But I also quite popular on the ward because at 6'2", the ward had a netball team. And I had actually learnt how to play netball at school, so I was quite a popular member of the ward netball team. I also learnt how to take blood, and so became quite popular with the junior doctors on the ward at the time, who used to regale me with stories of why exactly I really shouldn't do medicine and get out now while I still could. But I ignored them. I saw some other interesting things while on the ward, and some of them were patients that I won't ever forget. So this is a picture that I saw every day during that first summer. It was on a bedside table of one of the patients, let's call him Mr. S. And Mr. S was very unwell. But like many of the male patients on the ward, when they needed to have their daily bed bath, they actually preferred me, the male healthcare assistant, to do it, rather than some of the other female nurses on the staff. So I got to know Mr. S really very well indeed. Now I'm going to show you a picture. If you're of a slightly queasy disposition, I suggest you close your eyes briefly. But that's what Mr. S's hands looked like when he first turned up. And they got worse. They became completely black, as did other parts of him. And he was sadly went on to lose them. The same process actually affected his tongue, and as I was taught, affected his kidneys, and he developed kidney failure for the rest of his life. But what I saw while this man was in hospital was a very sick patient with a huge number of very attentive people looking after him. There were all the nursing staff, the other healthcare staff, physios, nursing therapists, doctors, all sorts of people helping to look after this man. And when he got better, it wasn't just a success for him. He was obviously delighted, but it was also a huge success for the team. And the team really did bond over their successes, and it made me think that that was a team, a bit like my football team at Dunmore, that I wanted to be a part of. While I was there, it's not going to work. I met some other people, not patients to forget this time, but some colleagues that I'll never forget. So Chris is in the audience here, Chris Winnells. So this is, I think, a bit what he looked like when I met him back in 1994. And I can remember one of the first times we met very clearly. I was the healthcare assistant on the ward, and in those days, consultant ward rounds were the real deal. Nowadays, when we do consultant ward rounds, you're lucky if one or two people come with you to help you write a few things down. But in these days, Chris turned up on the ward, followed by the senior registrar, followed by the 2 registrars, followed by the 3 SHOs, followed by 4 medical students, sister, the nurse in charge of the ward for the day, the physiotherapist, the dietitian, the pharmacist. They were all there in train behind Chris, walking on the ward for one of the twice weekly ward rounds. And Chris, in his way, I was just doing my thing, but he spotted me, and Chris hadn't met me before, and as he does, he makes everybody on the ward feel comfortable. So he came over to introduce himself to me, to find out a bit more about me. And when he got close enough, he could read my name badge. And so he said, Haynes. Are you any relation of David Haynes? So David Haynes was my father. David Haynes taught at Abingdon School, where Chris had sent all 4 of his sons, and my father had tutored all 4 of them. So in fact, we had quite a lot to bond over, so we had a nice conversation. Unfortunately, for the ward round that was supposed to be going on, they were less impressed. I was slowing things down, and I was the healthcare assistant. What on earth was I doing holding up the consultant on his ward round? But Chris did a lot more for me than that. He told me about Mr. S. He explained to me in great detail the diagnosis, Capnocytophagia canemosus. It's a bacteria that lives in the mouths of some dogs, and if you're unfortunate enough to be bitten by the dog, then these sorts of things can happen to you. He told me to go and read up all about it, because that would be probably the only case I would ever see in my career. And he was almost right. Actually, when I was doing my wind on about 6-7 years, I was doing my revision lectures just before finals at Oxford. Patrick Maxwell was giving the lecture. He's a nephrologist, kidney doctor, many of us will know, and he's now Regis Professor of Medicine in Cambridge, but he was showing some cases, just getting us warmed up a couple of weeks before finals. And he put a picture like that of Mr. S's hands up, And he said, well, this man's got acute kidney failure. You won't know the cause, but just have a guess. So I put my hand, I didn't need to guess. I knew those hands very well indeed. So I just put my hand up, he turned to me, well, what is it then? And I said, capnocytosis vagicanomosus. The lecture theatre went completely silent. Patrick Maxwell couldn't work out how I knew, was pretty cross that I knew. But it was nowhere near as cross as everybody, my fellow medical students in the audience who thought this was completely unfair, 2 weeks before finals, that somebody should know this. And was this really required for passing finals? Because if so, we're all in trouble. So Chris has helped me out a lot there. Chris gave me careers advice and throughout. He's been a fantastic mentor to me. And he's also been a great friend to the family. My father, who can't be here, he died nearly 10 years ago from kidney cancer. At one point, there were thoughts that he might need to have both kidneys taken out to try and treat the cancer, which would have turned him from a man with normal kidney function into a dialysis patient overnight. Chris very kindly agreed to see him, to talk to him about this possibility, to see if it was something he wanted to do. And something that has stuck with me ever since, and I think stuck with my mother too, was that my father, being the sort of man that he was quite worried for me in this situation, because he knew that having a dialysis patient in the family wouldn't be any fun for a kidney doctor. And so he said to Chris, well, what about Richard? How's he going to cope with this? And Chris just had a very simple answer. He said, well, you don't have to worry about Richard. The kidney unit will look after him. So I was always very grateful for that. So thank you, Chris. I also met some other colleagues on the kidney unit. I met many colleagues on the kidney unit. I'm very grateful a number of them have turned up, and I can't mention them all. But Phil Mason there, sitting on the left, he was in charge of training the doctors the entire way through my training in renal medicine. He appointed me as a senior house officer, then as a registrar, and saw me out the other end as a consultant. And I'm always really grateful for Phil, because he had very high standards. If you're going to be a doctor working for Phil, you had to be a very good doctor to get through that. So that was excellent training in itself. But he also wanted to see a broader picture. He didn't just want to run a machine turning out doctors. He always saw the broader picture. So when at one point in my training I wanted to go part-time so I could continue to do some research, and I was struggling to persuade the officials in charge of training that this was a reasonable thing to do, Phil thought up a very imaginative solution and managed to make it possible both for me to come and work part-time in the kidney unit and part-time here to continue some of my work, but also for Marion Maffam on the other end of the slide there to return to work. She'd just had her first child, was struggling again with the authorities to get back in, less than full-time training, but Phil combined us in a job share role, and it worked out brilliantly for both of us. Now Marion is my forerunner here at CTSU. She was the first kidney doctor to come here. So we have to thank her, because she taught CTSU just how special kidney doctors can be. And actually we are very useful people to have around. But the couple of years of my training that I had just towards the end when I was job sharing with Marion were also some of the most terrifying training I've ever had. Because Monday to Wednesday I was on ward duty or clinical duty, so I would go into the hospital, do my job, and then I'd have to make a list, and on Wednesday lunchtime speak to Marion and hand over to her, in full knowledge that Marion was then going to spend the rest of the week scrutinising every decision that I had made up until that point. And she was very gracious to me. She only very occasionally asked me why on earth did I do something, I think when it was particularly important and an obvious gap in my knowledge. And then the final person on this slide is Chris Pugh, who when I first met him was one of the senior registrars on a ward round with Chris Winnells, but has clearly had a fantastic career as a scientist, very much a basic laboratory scientist in the field of oxygen sensing. But he's also been very kind to me. He accepted that I wanted to be an epidemiologist and have nothing to do with a basic science laboratory, which was probably a good thing. I'd have broken a lot of instruments if I'd been let loose in a basic science laboratory. But he didn't mind that, and he still has given me wise advice throughout my career about the best approach, what things really matter, what things don't matter. So I'm always very grateful to Chris. And then they introduced me to this man. When I said I wanted to do epidemiology, which was a bit novel for the kidney unit, first of all I was sent to see somebody who works in the Department of Primary Care. You could have got away with it, Rory. Unfortunately, that gentleman had slipped a disc in his neck, so he couldn't see me. He was on bed rest for 6 months. And so I went back to Chris Winnells and said, well, do you know anybody else? And he said, well, there is somebody called Bajent. Why don't you go and have a chat with Colin? So I got in touch with Colin, and he very kindly agreed to meet me in this. I can remember it very clearly. here in this building. CTSU hadn't long moved in here, I don't think, at the time. But as I was sitting in the waiting area just upstairs, waiting for Colin to come and find me, I was thinking, well, what on earth can I talk to Colin about? I felt very underprepared. I wasn't entirely sure what we were going to discuss. So I was sort of scrabbling around for ideas. And then when we got up to Colin's office, he kindly made me a cup of tea. But in those days, it's less common now, but senior staff at CTSU tended to use their floor as a filing cabinet. So you could see all the pieces of work that they were working on laid out neatly on the floor. And I think that was because they were unused to having such large offices, having just moved up from the Radcliffe Infirmary. So they would cover the floor to cover their tracks or something. But I did notice that Colin was working on aspirin, and suddenly the light went on in my head. Because, like many junior doctors, I avidly read the New England Journal of Medicine, and I too had read an article about aspirin recently. It was this article from a group in America who had found some evidence to suggest that aspirin didn't work as well in women as it did in men. And I can remember saying to Colin, thinking, this is what I can show him great insight here. So I said, aspirin's very interesting. It's interesting it doesn't work as well in women as it does in men. And if anybody knows what Colin spent a lot of his time doing, it was disproving that very that thesis and hypothesis and many others like it. Colin was very gracious to me. He just explained coolly and calmly why one single article couldn't necessarily prove it, and if you looked at all the evidence together, actually aspirin seems to be equally efficacious in both groups. But Colin invited me back to talk some more, and started talking to me about what I wanted to do for research. So he really opened the door for me here at CTSU. At about the same time, I was also talking to these two people, so Paul Harden, another kidney doctor, and Professor Peter Friend from the Nuffield Department of Surgical Sciences, were very keen to set up a trial in kidney transplantation in the UK, testing this molecule on the right-hand end there. That molecule was called Campath. A molecule named after the Cambridge Department of Pathology, which looked like it could have exciting uses in the field of kidney transplantation. So I was beginning to see a few pieces of the jigsaw coming together, that there was a fantastic trials unit, and here was what I thought quite a good trial to be done. So I'm just going to digress slightly and tell you all I know about randomized trials on one slide. And this is pretty much it. If you want to know whether a treatment's any good or not, you must use randomization to decide who gets the treatment and who's in your control group, to make sure you're comparing like with like. And the second thing you need to do is you need to do that as many times as you possibly can. Recruit as large a sample as you possibly can, so you can minimize that play of chance. And I think this is an example. I didn't come up with this, but this is a good example of why we really need randomization. I think it's coming under threat now. When it was first posited as a way of testing treatments, I think some people thought it was unethical. But that's been dealt with. There is no reason why it shouldn't be possible to do randomized trials from an ethical perspective. But nowadays, the threat actually doesn't come from that side. It comes from people who think that because we have fantastically large computers with very large databases in them which record all sorts of things about people, including whether they got treatment A or not, we can just use those to decide whether the treatment works or not. You don't need to bother with randomized trials. You can just use your computer to decide. But I think this is quite a neat example. Here are two people who most of us will know. For my children, the one on the right is this man called Ozzy Osbourne, who used to play guitar for Iron Maiden. But I think you could probably guess, looking at those two, that we would expect them to naturally have quite different health outcomes. But we know quite a lot about them, so if we go and look in our clever computer and its database, we can find all sorts of things about them that they are actually remarkably similar. And so the computer would think that these two people are actually going to have quite similar health outcomes. But we wouldn't. I think we would probably understand that you would expect some differences here, because we know there are unmeasurable things between those two. Maybe they are measurable, but there's certainly differences that we can see which the computer can't. And that's why you need randomization, to make sure that when you've got your two groups, you've got the same number of Kings and the same number of Ozzy Osbournes in both your groups, and things can be comparable. So I was really getting the bug for randomization. I could see the real need for it. And so Colin very kindly invited me to come back and have a chat with Jane and with Martin, because they were just in the process of setting up a new trial, a trial called Thrive, HPS2 Thrive. And I can remember again sitting in Colin's office, And Jane very kindly explaining to me about what this trial was about. It was about a drug called niacin. It was going to have effects on triglycerides, an effect called cholesterol. And to my shame, I can remember saying to Jane, I don't find cholesterol very interesting. I'm much more interested in creatinine. And I can remember talking to them a bit about the kidney transplant trial that I was interested in, which at that moment was little more than an idea in anybody's head. And Martin saying something which, looking back on now, I can see a different meaning. He said, that sounds like a really good trial. I'd be delighted to work on that with you when you raise some money for it. I didn't see a problem with that, but I think it was Martin essentially telling me that I could take a running jump because that trial wasn't happening anytime soon, but this one was. Fortunately, after I'd offended Jane and Martin, Colin spoke some sense into me and pointed out that actually when you're thinking about trials and learning how to do trials, it doesn't matter hugely what the topic area is. This was going to be in cardiovascular disease, it could have been in kidney disease, it could have been in cancer, it could have been in anything, but you learn the skills, and actually these two people were probably two of the best people in the world to learn their skills from. So don't be so silly. Come and work on this trial, and we'll let you work on your transplant trial as an extracurricular activity, if you like. So I did. I applied for a job. Jane forgave me at interview, and I came here in 2006 to work with those two. So when I first came to CTSU, it was to work on Thrive, but I met these two. So on the right there, Richard Bulbullier, who told me very early on that the only reason I was coming because he was leaving. And he was leaving, and because this is CTSU, it was one Richard out, one Richard in. And that was the rule. So Richard put me in my place pretty quickly, but I also spent a lot of time with Louise, who has trained a lot of junior clinicians in her time, and she gave me a fantastic introduction into how trials work and how they really work, not just what you can learn from a textbook, but how you really put principles into practice. So I'm always grateful to Louise for that. And one of the trials I was working on was a trial called Ascend, which was a study run by Jane and Louise, which was recruiting people with diabetes to see whether they would benefit from aspirin or fish oils without ever actually meeting these people. So it's quite a recruitment challenge. And one of the areas they asked me to help with, it's back in 2006, so it's right down here at the bottom left of that graph, was to come and help with recruitment because they were struggling to recruit. And so you can see after a couple of years at CTSU, I had absolutely no effect on that recruitment rate, but I did learn an awful lot about it. And Jane also learned how to manage me very effectively because she would offer me gold stars if I could bring in a collaborating doctor with a large data set of people with diabetes. So off I went to collect my data sets and my gold stars, and then she offered me 2 gold stars because we'd heard of a data set in Wales which had information on everybody in Wales with diabetes. So little did Jane know quite what a misery she was making of this poor doctor in Wales who ran this data set, but I hounded him incessantly, trying to get him to collaborate with us. He then retired, and then I hounded the person who took over, and they did take part, and Ascend fully recruited. Also on Ascend, I got to just sort of dabble in one of my other loves. So I've shown you I love hill walking, I also love high mountains, and I was put in charge, I was made the first editor of the Ascend participant newsletter. So I got to choose everything, including the title. So I called it Himalaya, and that gave me carte blanche. Then every edition was going to have a little bit of information about some of the high Himalayas. So this is issue 1 with a picture of Everest in it. And so I enjoyed writing my little paragraph about Everest. And then I think some of the other doctors, including Marion, who followed me, then cursed me ever since because every time they wrote an issue of this newsletter, they had to come up with their little paragraph about a high mountain. So just to save you Googling later, here are the 40 highest mountains on Earth, all of them over 8,000 metres high in order. But back to Thrive then. So this was my main project, if you like. And I was working on Thrive. What I'm showing on this slide is some data from other people who've worked at CTSU. Sarah Lewington produced these data. I used to frequently have lunch with Sarah when I first started here, which shows a lot of what we take for granted now. But CTSU was the place that really showed it. So on the left here we have bad cholesterol, or non-HDL cholesterol as it's called. The higher your level of that, the more likely you are to have heart disease. But then we can see on the other side, HDL cholesterol, sometimes known as good cholesterol, which goes the other way. So it seems to be that the higher your HDL cholesterol, the lower your risk. But what we didn't know before Thrive is whether actually raising somebody's HDL cholesterol was a good thing to do for them or not. That was largely unknown. Largely because we didn't have a tool to do that with. We didn't have, statins are very good for the bad cholesterol, they reduce that and we know they reduce risk, but we didn't have a statin, if you like, for HDL cholesterol. But niacin looked like it might fit the bill. Niacin, we all recognise this, you've read it on the side of your cereal packet this morning, it's vitamin B3, we all need it in certain amounts, but if you give it in pharmacological doses, like grams rather than micrograms, then it does all sorts of good things. It reduces your bad cholesterol, it reduces other fats in your blood like triglycerides, it can reduce your blood pressure, and it can increase good things like HDL cholesterol. It had been in use for 50 years. It wasn't very popular because it had some unpleasant side effects, in particular flushing, where you feel hot and red and can be distinctly uncomfortable. But we were fortunate enough to be offered to do a trial of a formulation of niacin which was hopefully going to do away with some of those side effects and make a test of it practicable. Just tell you a little about the design of Thrive. So when we recruited patients into the trial, first of all, everybody got put on a statin because we know everybody with cardiovascular disease needs to be on a statin. And then we gave everybody a chance at taking the new drug to see whether they could tolerate it or not before we went to randomise them. But what we've discovered early on was that about 1 in 3 people that we gave that active drug to took it for about a week or two and then said never again. They weren't going to take part in the trial. And we found some interesting things about the side effects of the drug from that. And Jane said, well, you could do your higher degree, your research thesis while you're at CTSU on that information. So that's what I did. But Thrive went on. As happens in CTSU, research theses don't always get produced precisely when you might want them to. And so actually the trial came to an end, and it came to a slightly disappointing end. This was the first big trial I'd worked in, 25,000 patients recruited in 6 different countries. I'd started working on it in 2006, Jane and Martin and others had started working on it before that, and here we are in 2012, so at least 6 years later, looking to see whether niacin was any good or not. So here are all the things that we were hoping the drug would prevent, like heart attacks and strokes. And here we have what we call a forest plot, showing overall that actually this drug has no real effect on those outcomes. It's certainly no good for people that you want to prevent vascular disease in. So that was attacking 50 years of dogma in cardiovascular medicine, that niacin doesn't work, but it hadn't had a proper trial. So it hadn't had an opportunity for anybody to do this analysis, which we did pretty quickly. So this is now looking at everything apart from vascular disease. So really, if you've got a drug to reduce vascular disease, you want to have no effect on any of these things. You want it to be a benign drug, well tolerated and safe. But where you can see here, all these boxes, nearly all of them are to this right-hand side of the line. And the right-hand side of the line tells you that placebo would have been better for you, which is a pretty damning indictment for a trial treatment. You don't want to be thought that placebo is better. And I can remember when Jane first saw these results, and she just said, that's the death of that drug. And sure enough, it was. As soon as these results became known, the drug was withdrawn from the market. And we boiled all of that safety information down into this slide. So this actually became the nub of my thesis. You can see here that giving people niacin was bad for them. If they didn't have diabetes, some of them developed diabetes. If they did have diabetes, it got worse. But what we in particular discovered was these 2 things. Infection and bleeding. We found that this drug was causing people to be admitted to hospital with infections and causing people to be admitted to hospital for bleeding. That had never been known before. This drug had been used for 50 years. And all sorts of harm was being done. There were probably hundreds of thousands of prescriptions of this drug a year in the US. So you just need to do a bit of maths, and you can see that there's actually substantial harm being caused by a drug, which everybody thought was doing the right thing, but had never been tested properly, and we did that in Thrive. While I was doing that in Thrive, I was, if you like, the safety officer. So as a clinician, I was responsible for sort of reviewing all of the side effects and problems that got reported with the drug. We had found clear evidence that the drug was harmful, but what I had to learn while I was working at CTSU were what we call the trial regulations about how to handle safety reports in a trial, which Kirsty Reith, I can see at the back there, she had a lot more expertise than me in this area, and she patiently taught me all the differences between these mind-numbing acronyms like AEs and SAEs and SARS and SUSARs and what's expected and what's not, all sorts of things which make little sense when you first read them, but she patiently taught me about them So I could at least understand the regulations, but it did teach me that these regulations just weren't fit for what they're supposed to be doing. They were not there, not successfully identifying the major side effects, because we never had infection or bleeding reported this way. Anyway, I had a fantastic material for my higher degree, sadly from a public health perspective, but I got my higher degree, and we had a fun day out at the Sheldonian when I got to wear the Doctor of Medicine gown, which I think is pretty much the most lurid gown that Oxford University can bestow. Anyway, time to get back to the kidney, at least temporarily. You'll remember I was telling you about Campath, and I wanted to do this trial to see whether Campath was good for people having kidney transplants. And so we came up with this idea of calling it the 3C study, and the reason we were doing it was that these lines here all show you how long people's transplants were surviving by when the surgery operation was done. And what it shows you is that really all these lines are just on top of each other. There hasn't been any meaningful improvement when this slide was made from the mid-1980s to the mid-1990s. And that was a bit disappointing, because kidney transplantation is an absolutely fantastic treatment for people with kidney failure. It is completely life-changing, but we weren't necessarily getting any better at it. I wasn't getting any better at art either, so I was very fortunate that somebody drew a much better symbol for the trial than me, because trials rely on, I think, two things. One is a good acronym, and the next is a good logo. But we wanted to find out in the 3C study whether we could try and address this problem of why transplants were failing. And one of the common ideas, it still is a fairly common idea at the time, was that one reason is that some of the drugs we give people when they have a kidney transplant, it's called CNIs, calcineurin inhibitors. Doesn't matter what they're called, but we give them to them. They're very good at preventing rejection early on, but if you give them to somebody every day for the next 10, 15 years of their life, unfortunately, they also have bad effects on the kidney, that they can scar it, especially if you give them too much. So we wanted to, in this trial, see if we could find a way of giving less of those CNIs to people who are having a kidney transplant, but without risking the kidney transplant in any way. And so these were the first results. This was a really proud moment. We set up the 3C study. We did get it funded. We managed to persuade enough people to give us some money. And with a small team of people here from CTSU, we recruited 850 people into the trial, which for a kidney transplant trial was a very big trial, even if not by CTSU standards. And the first thing we looked at was to see what effect our treatments were having on whether people had rejection or not of their transplant. So people get monitored very carefully after a transplant, and if somebody's suspicious that the recipient's immune system has started to attack the kidney, you can do a biopsy and see if you can find evidence of that rejection process. And what we found actually was the drug we were testing, this Campath, was really effective. It could about halve the risk of rejection in the first 6 months. But one of the reasons I really like trials is they challenge dogma. I've shown you that with the Thrive results already. But I remember when we were discussing these results, one thing I was told that was, that's fine, it can reduce rejection, but it's a very powerful drug. You're going to cause all sorts of trouble with infection by suppressing people's immune system too much. Well, so we collected information on every infection that these people had during the first 6 months, and the bottom line is it had no effect on infection, good or bad. So that was the first bit of dogma we denied. The second bit of dogma I had explained to me was that it's fine, you'll prevent rejection in the first 6 months, but then your Campath's going to wear off, and everything will just catch up, and it will be the same by the end of the first year. Well, not true. A year later, we're still just as much benefit as we had before. So that's one of the great things about trials, is that you can really challenge dogma. And I think it's one of the things that why he encouraged me to go into nephrology, because there's a huge amount of dogma around in nephrology, and it's worthy of testing. From there, I went on to work in the follow-up period on a study called SHARP. So SHARP was the world's largest trial in chronic kidney disease at the time. I hadn't worked on it while it was recruiting or following up, but Colin and Martin, who ran SHARP, very kindly let me work on the database. By myself, I wouldn't have been any further forward today. I might have just about managed to load it into Excel. But I was very, very fortunate to work with these two. So John Emberson and Natalie Staplin, two of the statisticians working here. I had a very productive time since then, working with them on these and many other studies. And it brings me back to my point about teamwork, is that running a trial, you can't do it by yourself. You need a really good team around you. Statisticians are very good people to have as your friends. They will point out your mistakes to you very quickly, and characteristically of these two is they very rarely make a mistake themselves. So it's been fantastic working with these two on these little projects, but also on other trials which have since followed. Still talking about kidneys, I then went on to work on a study called UK Heart 3. We wanted another trial. SHARP had been a roaring success, showed that kidney disease large trials in kidney disease were possible, but they were still very rare, and we wanted to repeat the exercise. And there was a new drug for heart failure actually, but which looked like it could be beneficial for people with kidney disease. So we set up a study called UK Heart 3, and I was told that I could appoint a clinical research fellow to work with me on this, which was great fun. And Paminda Judge unwisely applied for that job, and I'm sure has the sympathy of many people in this room now because she's still here, still working with me. And Rajiv Dayanandan, one of our trial managers, between us we ran a small team of people to recruit about 400 people, and unfortunately showed that this drug was no good for people's kidneys. It wasn't bad, it wasn't good. But we showed that, but there was no large trial coming out of this. So that's, as Rory's already given away, part of the reason why I returned to the NHS. I began to wonder whether my strengths were better suited to a clinical career. I really enjoyed working with patients. And so a rare opportunity for a job in the Oxford Kidney Unit, consultant job in the Oxford Kidney Unit came up, and so I applied for it and was appointed in 2016. And so I had a couple of years back in the NHS, which I don't regret for one moment. I think it completed my clinical training in a way which it wasn't complete at the time before. I got to be a different member of the team and really enjoyed the extra time that I got to spend with patients. But unfortunately, I was always nagged by the fact that there were these unanswered questions. We did need research, and I wasn't going to be satisfied by just a purely clinical career, that I did need to go back and start seeing if I could answer some of those questions. And I think that's important because I could have presented today as a very smooth transition from healthcare assistant to medical student, from medical student to doctor, from doctor to clinical research fellow, and here I am today now giving my inaugural lecture, but it was far from a smooth path. I wouldn't call this a bump in the road, but it's clearly a very significant change in direction. And what I haven't talked about are all the folders I've got in my inbox of other trials that we've tried to set up over the years, some of which have taken months, maybe more than a year's work, hundreds of meetings and planning, and then they don't, for one reason or another, they don't happen. And you go off and you have to do something else. So it's been far from a smooth path. I don't regret any of it, but I don't want to give anybody the wrong impression that in any way it's a smooth trajectory. So I came back in at the deep end because while I'd been away, David Price and Will Harrington had been working hard to set up a trial called EMPA-KIDNEY. I'm very grateful to David because when I came back, he essentially let me work on this trial and didn't have any problems with effectively handing over the reins, or his reins, to me to continue the work. And during this trial, I've got to work with Will Harrington, and working closely with him, it's been phenomenal to see what drive you can achieve with a sole focus on reliable results, which Will has brought to this and to pretty much everything else he does. This is the EMPA-KIDNEY recruitment plot. So these columns show you how many people we recruited each week. And you can see it's a very strange plot. It goes up very nicely, and then it just crashes and disappears before rising again. And that's, you can't see the dates down here, but this is spring 2020. So this is when the pandemic struck. But Will had made fantastic plans so that the trial never stopped. And actually, the colours mean different countries. And what you can see is in the second half of the slide, as we recover from the pandemic, we're led in particular by some red and some blue, which were China and Italy. Maybe not the most natural places to think about running a trial during the pandemic, but actually they were first into the pandemic. We've all heard of them. It also meant they were first out of the first wave. So while everywhere else was struggling on, under Will's leadership, these regions started to recruit well. And we didn't just recruit 5,000 people, which was the plan. We recruited over 6,500 people into EMPA-KIDNEY. So this should be the end. I can see the clock. It's not the end yet, but you haven't got much longer. During that time, I was encouraged by Jane to apply for this recognition of distinction, and so I hurriedly put an application together. One reason I'm the Professor of Renal Medicine and Clinical Trials is because I had very little time to decide what to do, and it was the first thing that popped into my head. And then it was somewhat of a surprise later in that summer when this letter popped into my inbox. When I got that, I was absolutely delighted. I then realised that I was going to have to give a lecture like this and would probably end up doing it in spring 2020. Obviously other things have happened since then, and that's why I'm here today about 3 years late. And this is largely what I've spent my time doing. So with credit to John, for this slide, I ended up working on a trial called Recovery. So we all saw the pandemic coming up, and I'm sure we all watched the news, heard reports first from China and then from maybe South Korea and Italy. And it became increasingly clear the pandemic was getting closer and the UK was not going to get away without being affected by it. And I can remember talking to people in the office about it. We didn't really know what was going to go on, but I did remember speaking to Martin and asking him, clearly we need trials. We have a disease here which nobody knows how to treat. A huge amount of dogma was getting generated pretty quickly, but nobody knew what they were doing. And I thought Martin might have an idea. And he showed me a protocol on a Monday morning, I think it was, and said, okay, you've offered to help. Here's a protocol. What do you think of that? And do you think you can recruit the first patient a week on Friday, please? Which actually we did. It wasn't. It was a rapidly put together a team, which I'll show you in a minute. But just as some trials were running into, or the NHS was running into a pretty chaotic time, we set out to set up a trial before chaos hit and ensued to make sure that the trial could be there and be running when hospitals were under pressure. And this is the recruitment plot again. So this is actually the number recruited per day on this slide. And you can see we got it going very quickly. And in the first wave, we managed to recruit nearly 500 people per day. To be honest, when I volunteered, I didn't really know what a pandemic was. And I thought, well, 3 months' time, it's all right, I'll be back working on EMPA-KIDNEY again, that'll be okay. And 3 months later, lo and behold, the pandemic seemed to have settled down. But people were saying that's really not the end of it. And here you go again. This was the winter of 2020, 2021, when things, if anything, got even worse. But the bars across the top show the treatments we were testing. So we were putting treatments in, and when we got reliable evidence of those treatments, we took them out again and published those results very quickly, and we've changed practice a number of times. But you can see these bars are not very long. We achieved in 100 days what it usually takes some trials 2 or 3 years to do. This is a sort of summary of the highlights of recovery, if you like. So here you go, first protocol on the 10th of March, first patient enrolled on the 19th of March. Thanks to a fantastic effort across the NHS, who really adopted this trial close to their heart. We enrolled 10,000 people by the 4th of May. And then just as the first lockdown was easing, we started getting results. The dexamethasone result is probably the one we might be known best for, where we show that dexamethasone reduces the risk of death in people who need oxygen. And I can clearly remember this result because about a week before, lockdown had eased. You're allowed to go and visit relatives as long as you sat in the garden. So we went off to Suffolk to visit my wife's family, sat in their garden, and I can remember John and Martin phoning me up because these results were just emerging, and clearly we needed to make a plan to get the results out there. So it was a rather bizarre experience. And as I left, I can remember saying goodbye to my father-in-law and just saying to him, make sure you watch the Downing Street briefing on Tuesday. I think there might be something to say. And then on Tuesday was the day that Peter Horby stood up next to Boris Johnson and announced that result. But it hasn't stopped there. The trial has delivered much, much more. It's also delivered something I didn't really relish, which Rory said at the start, was a close association with regulatory inspectors. So I've already mentioned some of the regulations that I found hard to follow and I didn't think were really fit. Well, the trial has obviously had a pretty high public profile, so the regulators have inspected it very carefully. We've had visits from the American regulator, the FDA, but also from the UK MHRA. And both of those inspectors found one of the things we did slightly challenging. Very early on in the trial, Marion and a team of data engineers and data analysts set up that we could access data not just when sites told us whether patients lived or died, because that was our outcome, whether people were still alive 28 days after they went into the trial, Sites could tell us that by filling in an online form, but Marion set it up so that we could find that out directly from the NHS. So when we die, our death will be recorded in the NHS pretty quickly, and if you've got the right permissions in place, those data will be available to researchers. So we got access to that, but that means we had two data sources on death. We had what the sites were telling us, we had what the central registry was telling us. Now, most of the time, the vast majority of the time, they agreed beautifully, but occasionally they would be discrepant, that one source would tell you they died and the other one would tell you they hadn't. And in the majority of those cases, there was a perfectly innocent explanation. For example, the patient left hospital, so the hospital had finished their work, they told us they were alive, but sadly died shortly thereafter, so the central registry did their work. But the inspectors were obsessed about these discrepancies. We were well aware that these discrepancies were going to occur, and so Marion had written a set of rules out very carefully describing what should happen in each situation, and that's what we went with. What the inspectors wanted us to do, though, was to look at every time there was a discrepancy, go back to the hospital and ask them to sort it out for us, which in the middle of a pandemic seemed a little bit unnecessary. When the number of events that this was affecting was very, very small, but what I found particularly hard to understand was why, when I showed them these three graphs, they wanted us to do that, because one of these graphs shows you the results according to Marion's rules. One of these graphs shows you the results if you only looked at what the hospitals were telling us, you ignored this central information. And one of these graphs only uses the central information, it ignores everything the hospital told us. And I challenge any of you to spot a difference really between those graphs. There isn't one, there is no important difference between these graphs, it doesn't matter. So the inspectors were going on and on about this, and I was just saying, it doesn't matter. It doesn't matter, and I think this is a very good definition of you can't see the wood for the trees. They were obsessing about every tiny detail of the data. They couldn't see the bigger picture, and this was just one example. That inspection sadly went on for 2 or 3 months, or 2 or 3 years as it felt like. But recovery is delivered and delivered more. Now, I do have a quote from David Brailsford, but I thought it was going to be on the screen in front of me, so I can't give it to you now. Precisely, but what he said, this is the man who transformed cycling for the Team Sky and the Great Britain team just before the 2012 Olympics, from being a bit of a basket case into being world leading. And essentially what he said is, if you could break down riding a bike into all of its constituent parts, and if you could then improve each of those parts by about 1% and then put them back together again, you will have a big effect on how fast people can ride a bike. And that, if you like, is sort of CTSU's mantra towards trials. We don't expect any one treatment to be a cure. You do get some treatments with big effects, but they're pretty rare. But if you put treatments with slightly smaller effects together, you can have a really big impact, and this is what recovery's done. So there's a few caveats to this, but back at the start of the trial, about 1 in 4 people admitted to hospital were dying in the first 28 days. But when we found dexamethasone, we reduced that to about 1 in 5 or 20%, and then these are the other treatments we've found to be effective, and you can see we've just chipped away at that. So we've taken what started out as a 25% death rate down to something more like 12% in one trial in just over 2 years. So it shows really what trials can do if you let them. But recovery was only possible because of an amazing team of people, and this team was astonishing. Partly because many of them had never worked together before, and in fact it took several years before some of these people ever met in person. I can remember, I don't think Peter's here, so I can be rude about him quite safely, but when John met Peter for the first time, Peter Horby, one of the chief investigators, and remarking on how short he was, because he'd only ever seen him from the shoulders up on Zoom. I also learned that you really can't sing happy birthday to anybody on a Teams teleconference. It just doesn't work. But this was a remarkable team of people to bring together. It brought together people from CTSU, it brought together people who worked the floor below CTSU, the National Perinatal Epidemiology Unit, worked on this trial. It brought people out of retirement who thought they'd escaped. It delayed some people going into retirement. We brought this team together who didn't know each other but rapidly built a close rapport so that people came to trust each other, and we could deliver things in days which were usually measurable in weeks or months. But Martin here and Peter really showed quite astonishing leadership of that, because I don't think anybody really knew what was going to happen, but we managed to keep this trial going and delivering. And it's delivered not just for us academically, but it really has had a major impact on health in the UK and around the world. And it's also made other countries around the world look at the UK and think, well, why can't we do that? Why can't we set up trials like this? And hopefully they will one day. It also taught me the value of being able to take the credit for everybody else's work. And if you do that, you get to have a very nice day. Just occasionally, you'll get a very nice day out at Buckingham Palace. And that day was a lot of fun. My particular favourite moment from this was when Jane and I emerged from the palace. There were a big crowd of tourists here at the gates, as there always is on a sunny day in London. And Jane spotted our family and gave them a hearty wave. I think all the tourists thought that a member of the royal family had just appeared and was greeting them. So they were very happy to see us. When we apologised and explained what was going on, they still took the picture for us, which was very nice. Another thing that recovery taught me was that it's quite dangerous to get to know Peter Horby, because he'll then involve you in other projects. So this is a pretty rapid introduction in how to put level 3 PPE on, and then a week or two later, this was me taking a picture at an Ebola treatment unit in Uganda. I can't say I'm not relieved there were no cases of Ebola in the Ebola treatment unit that day, so I didn't get to practice my training, but we are seriously thinking about how you could run a trial a bit like recovery for other diseases, infectious diseases around the world. But in short, what next? Well, we need more trials. I think that's clear. There's all sorts of dogma that needs to be challenged. There are going to be new treatments that come along that need to be tested. We are going to need more trials. And to do that, it's going to be essential that CTSU continues to lead. We've been incredibly fortunate with the leaders that CTSU's had, and we need to maintain that leadership over the years so that we can show not only ourselves but many other people around the world how to design your trial and how to conduct your trial, how to analyse your trial and produce results which can change public health. But we can't do this all ourselves. We're going to need other people to learn our methods. So we're going to need to not only show by example, but also teach many other people and facilitate trials run by other groups in many other ways. So I'm going to finish now just with some personal thanks. So on the left here are my parents, just finishing the Milford track in New Zealand. I mean, obviously I'm completely indebted to them. My mother, I think, has worried about her little boy every day for the last 40 or so years. And I hope hearing something of what I've said today has encouraged her that it hasn't all been in vain. But for their undying support throughout everything I've done, I'm incredibly grateful. And they've taught me so much more about how to interact with people than you could ever write down. And then on the right is my brother. I said I learned at Abingdon School what it's like to not be the cleverest person in the room. Actually, I got that lesson very early on in life. My brother's just a couple of years older than me, and he very rapidly taught me that if he was in the room, I was only ever going to be second best. I'm incredibly proud of what he's achieved. But he's not here this evening, so I can tell you now that his inaugural lecture, which he gave, he would point out 9 years ago, so I'm slacking somewhat, but his inaugural lecture has been viewed over 3,000 times on YouTube. So all I need you to do, please, is go home and tell everybody you know, just to view it. I don't think you have to watch the whole thing for it to count. But my biggest thanks has to go to these three people sat down here at the front. They keep my feet on the ground. They definitely ask me the hardest questions, but they definitely also give me the greatest joy. So thank you very much, and thank you all for listening.
Richard, thank you very much for a fabulous story, and just something to remember today from the department. And I hope everybody will come out and quiz Richard a little bit more about what he's going to do next at the reception. So thank you very much for coming today. Thank you, Richard, again, and thank you to Richard's family for lending him to us for all of this work. Thanks very much.
Thanks very much.